I'd like to thank the organizers again for inviting me and congratulate them on a very successful meeting with a wonderful program. And the previous speakers have actually made my task somewhat easier by covering some of the same issues that I'm going to cover. But I am going to be talking about negative pressure rather than ventilators. In fact, this subject is what got me on the course of this whole area and a lot of my physiological research. When I was a resident, I was actually arguing this very point on PULSUS PARADOXUS with my junior, which is well known to many of you, Jim Russell and I were arguing this. And it really started me down the path to where I am now. Now, the problem is, I'm not sure if I still know the answer to this question. It's a complicated one. So, there's two general categories that I'm going to look at. There's really the cardiac tamponade and then the increased airway resistance group, which would be asthma and COPD exacerbations. And it all comes down from Kussmal in 1872, who reported 4 autopsies of patients with primarily constrictive pericarditis, and one of them showed this variation in arterial pulse. And he called it paradoxical because the pulse he felt at the wrist disappeared at the same time as he could feel an apical impulse or auscultate the heart. So he could feel the heart beating, and yet he can't feel anything peripherally. In that same paper, Kussmal actually presents Kussmal's sign. One paper, 2 big things, pretty good. Kussmal's sign, I'll just briefly comment on that. That's the inspiratory increase in central venous pressure, and it indicates a limitation to right ventricular filling. Now, it's often thought that this could be due to a decrease in the pressure gradient because of the decrease in pleural pressure. So the simplistic thought is, oh, you breathe in, your pleural pressure goes down, therefore you get more blood back, the heart can't handle it, and the pressure goes up. It makes no sense. If the pressure went up in the right atrium, you decreased the gradient, you didn't increase it. So the real answer is not that. Since the CVP increases, the gradient is actually decreased. So the answer is abdominal pressure increases, and that actually drives more fluid out of the abdominal compartment back again. This was really nicely shown by Takeda et al. With Jimmy Robotham, where they did a beautiful study in animals demonstrating this point. Okay, so let's get on to PULSUS PARADOXUS. I heavily used there's 2 reviews. This one by Bilchik and Bob Wise in Lancet, which gives a nice historical perspective, and I've used their figures of Kussmal from that. And then with Ulf Hamzoui, who's very close to Jean-Louis, and their paper on PULSUS PARADOXUS, a really nice review on the subject. So the definition is an exaggeration of the normal decrease in arterial pressure with inspiration, and the number is a greater than 10 decrease, arbitrarily chosen as the value to call it an abnormal value. There's also a nice old review by this person, Maurice McGregor, who's the person who ended up recruiting me to my job, actually, and it was because of this paper that I wanted to move to Montreal and work with them because I was so impressed by it. So it has an emotional value to me. So what are the theories? Well, from that paper by Wise and company, there's a lot of theories. So the first one is an impaired pressure transmission. This is by Katz back in 1924. He said there's limited transmission of the pleural pressure to the interpericardial structures. Frankly, I don't know how that could do it. And that just doesn't make sense to me. So I'm going to get rid of that one. The second one was by Hitzig, which is pulmonary venous pooling. And he's argued that the compliance actually increases in the pulmonary circuit and takes up volume. Well, first of all, if anything, it's going to be decreased, not increased. And compliances, in contrast to capacitance, don't usually change in vessels. So I'm getting rid of that one. Dornhaus in 1942 brings up something that is probably closer to the point, especially for, as you'll see, for cardiac tamponade, and that is restriction of left ventricular filling during inspiration deforms the pericardium. And we'll come back to that concept. There was this one by Dock, where he said that as the diaphragm descends, it tugs on the pericardium and thereby squeezes the heart and then affects the compliance of the whole heart. But once again, patients with deep breathing that we see all the time, they don't get a PULSUS PARADOXUS, so I really don't think that's one I'm going to deal with either. The other 2 are important. There's variations in the systemic venous return, and Shabatai wrote about this in 1965, where you get increased respiratory variability and systemic venous return, and that I think is important. There was the afterload theory that came out of the Hopkins group. Summer was the first author, with Saul Permit driving this program. And the idea is that increased impedance to left ventricular ejection from the negative pressure is important. And then finally, there's the issue of ventricular septal interaction, which I think we're going to see is very important in the cardiac tamponade type. So these issues have been covered. I'm going to go over some slides that I covered in my other talks because they're highly relevant, my other talk, highly relevant to this subject. So cardiac output itself is determined by a return function, which determines how the fluid drains back to the heart because of the elastic recoil, and a cardiac function, which then determines the cyclic part of the function and pumps it back out again, and where these two intersect to find the actual working CVP, working right atrial pressure, working cardiac output, working venous return. And then I mentioned last time there's a cardiac limited side, we just heard a lot about that, and there's also a return limited side when the great veins collapse as they enter the thorax. So I showed this last time, that a normal breath results in the heart becoming negative relative to the rest of the body, and it results in that inspiratory increase in venous return. I also mentioned last time there's a series effect. The left heart can only put out what the right heart gives it, so if I have that change in right heart filling, that'll gradually get passed on to the left side, so that's going to create that cyclic change. And I also mentioned this point about when you lower the pressure around the heart becomes more negative relative to the rest of the body, so now it has to overcome that negative pressure, which creates an afterload for the ventricle during injection. So a negative inspiration creates an afterload on the left ventricle, and the bigger the negative pressure, the greater that afterload. So those are all concepts I went through last time. And then I actually did this one, which becomes very important in PULSUS PARADOXUS. So this was going through the pressure volume loop. You have the aortic valve opening, ejection, relaxation, and back again. And I said that when we lower pleural pressure, we've changed the reference point for this graph. So what happens, the whole pressure volume loop and graph moves downward. And it presents this interesting shift in the end systolic pressure volume line. It means that we have to have a greater isovolumetric contraction before we get to the top, which is that change in afterload. And it also means that you decrease the stroke volume. So on that very first beat, the arterial system doesn't know that the pleural pressure's changed. The heart sees that original diastolic pressure that is not affected by anything happening in the thorax. So on that very first beat, it tries to get up to that same old pressure. So because of that, you're going to get a marked decrease in stroke volume immediately. It's on that first point where the pressure falls. So there's an immediate fall in the stroke volume. Now there's a transmitted pressure change, but there's also an immediate change in stroke volume because of these characteristics. Okay, so those are the basics. I think points are labeled there. So that decreased stroke volume and the shift in this end systolic pressure volume line. So it's strictly a reference view that results in this graphical change. So putting these together, the effects of a pleural pressure change. So this is an arterial pressure to begin with. With inspiration, you have this fall in the arterial pressure, and then during the expiratory phase, there's a slight increase. So during the inspiratory phase, the primary effect is transmitted, because once the valve is open, you're now functioning from a lower value, and that immediate effect on the stroke volume. So that occurs right away. And on the expiratory side, that's going to be related to the increased venous return to the right side, passing through the system with that series effect, then causing that pressure to rise later on, creating the changes of the pulse. So let's look at the two conditions now. Let's look at it in asthma, and then I'll look at it in tamponade. The most dramatic ones are really I'm using asthma as a group. You would also see this in a severe COPD exacerbation or any patient who's really gasping on the ventilator. Any of those will do the same. And these can be really large, up to 40, 50, I think I've seen even more millimeters of mercury, really striking on the monitor. So the increased negative, so a large part of it is due, in my mind, to the increased negative pressure, because they're really pulling in. So this results in an increased venous return, but this depends upon the initial right atrial pressure because of venous collapse. So if the person's on the dry side, then they actually can't suck in more fluid. But it's occurring right away, and it's large, so it's got to be more than that. So this is the point about if the right atrial pressure was 0, for example, you wouldn't actually have any increase in venous return. So that part probably plays a role, but it can't be the primary part. I think the more important part is, one, the direct transmission to the artery, and that fall that I just showed you before, and the changing position of the pressure volume loop. To take this one a step further, so that very first speed I showed you before, but if the breath is more sustained or during the cycle, what's going to happen, whoops, I had it there. Yeah, on the, I'm missing a line. On the next beat, I must have blocked it. No, I blocked it out, sorry. On the next beat, I'll just try to explain it. You would actually, now the aortic pressure would be lower, so you would start from a lower value and eject from a lower value. So first you would have it because you immediately decrease stroke volume, but then the pressure will be down because everything is occurring from a lower level with the decreased intrathoracic pressure and transmission of the pressures to the arterial system. So they're going to combine. Now, Francois Jardin, this paper was referenced yesterday, and I think it's actually a very important concept that might be contributing a lot to this because of the large changes that we see. And he said that the effects of PULSUS PARADOXUS in bronchial asthma was because of the increased venous return that we talked about, but instead of the left side, he said there's actually an increased load on the right ventricle. So we got into a discussion about this yesterday, or at least I did, with Michael, and maybe I'll reconvene that article. Plus, I don't have him to oppose me because he's gone. So I win. So I mentioned this point. I left out these slides yesterday, but I thought I'd better go through them today because it's an important point. So the point is that when you inflate lungs with a transpulmonary pressure, when that alveolar pressure becomes greater than the pulmonary venous pressure, you create a vascular waterfall, a zone 2, or if you're even more severe, a zone 1 condition. And when that happens, alveolar pressure becomes the back pressure, the downstream pressure for the emptying of the right ventricle. So the two approaches to lung inflation and PVR, the one that is classically talked about, has been shown a few times at this talk, was by this meeting, is by Wittenberger in 1960. And the second author, as I mentioned the other day on this paper, is Maurice McGregor, who wrote that PULSUS PARADOXUS paper, who's the person who recruited me to McGill. And he agrees that this paper is wrong. So in that concept, what they did, they had a pulmonary artery pressure measurement and a cardiac output. They assumed the downstream number is the left atrium, makes sense. And then they looked at different values of pulmonary artery pressure and flow with increased lung inflation. So they get this progressively decreasing cardiac output as they inflate the lung. And so it looks like you have this curvilinear relationship of resistance against the change in alveolar pressure, steadily increasing as you inflate the lung. But Permit's comment, he studied isolated lungs, inflated them, looked at controlled pressure-volume relationships, and now was able to get 2 or more points on a pressure flow line. And when he did that with lung inflation, what he saw, there was no change in slope, but in fact, the intercept change and the slope, which is resistance, 1 over resistance, actually stays the same. So in his model, there's no change in resistance, but what you do is you change the outflow pressure by compressing the pulmonary veins. So that's the importance of that, is that downstream number becomes very important. Now, certainly doing positive pressure ventilation, from some recent work I've been doing, I think it's actually quite common that at peak inspirations you create zone 2 and maybe even zone 1. And I suspect that with major inflations you probably are, which I think is what Jardin was seeing and would explain his results. And it may be much more common than we realize. Very difficult to assess because with negative pressure breathing you need to know the alveolar pressure to calculate the transpulmonary pressure, versus positive pressure, you pretty well know what the alveolar pressure is. So it's much harder to assess, but I think it's probably a common occurrence in severe cases. So when that happens, this critical pressure becomes the downstream number, and for every millimeter rise in alveolar pressure, you will get a 1 millimeter increase in the load on the right ventricle. Now, the last one is a rise in abdominal pressure during expiration. So when abdominal pressure rises by the diaphragm descending, that pressure is transmitted to the pleural space. So this would occur if you have an active expiration or recruitment of expiratory muscles. It's similar to what happens in a hepatojugular reflux. So again, going back to the Takata paper, this is a study we did looking at hepatojugular reflux to define limits of right ventricular filling years ago. So the point here is that if you raise abdominal pressure, you will shift the venous return curve to the right because you're adding an extra force on top of that. So you're effectively changing its compliance in a way. And so that will actually transiently, or more than transiently, if it's enough volume, raise pulse pressure. So you can see this. If you just do a hepatojugular reflex and watch the monitor, you'll see the arterial pressure go up. So, okay, so why is that important? Well, here's an example of somebody with a pretty significant looking pulse pressure variation. Although the pressure, actually the waves change, the pulse pressure does change too. Would this person be volume responsive? So this person got 500 mLs of pentaspan and had no effect on blood flow. This patient actually had a marked abdominal recruitment. So here is the central venous pressure in this person going from 0 to 30, and you can see the rise in pressure with these active forced expirations and then the decrease in between. And volume will have absolutely no effect on this person because it has nothing to do with volume. This is another example. You can see a marked pulse pressure variation. In this case, this was actually due to a pacemaker syndrome. This person had AV, atrioventricular dissociation, and canon A waves, and you can see them here. These are the canon A waves. Here's the arterial tracing again, and these are the canon A waves producing this pulse pressure variation, which has nothing to do with volume. Now, what about tamponade? So the effects are smaller in tamponade, 10 to 20 millimeters. A very important guide, though, to knowing that you better do something soon. I think it's primarily due to restricted filling of the cardiac chambers. So you get increased ventricular interaction, combined with the forces that increase right-sided filling and decrease left-sided emptying. So it's like a piston. So you're putting it in at one end and blocking it at the other end. An important point is the volume of the pericardial sac remains constant when you have tamponade. And I'm going to illustrate this interaction point. This is a wonderful old study by Atherton published in The Lancet in 1997. And he took 3 groups of patients. One group had compensated heart failure, meaning they were on diuretics and nicely controlled. One group was uncompensated, and another group was normals. And what they did is they've applied lower body negative pressure and looked at the changes in the left ventricular volumes by echocardiography. So in the normal group, you can see there's a decrease in left ventricular volume and diastolic volume with the maneuver. But the heart failure patients actually had an increase in their left ventricular volume when they applied lower body negative pressure. And the logic is like this. So we think of an RV and an LV. If I overfill the right ventricle because it's not emptying and not working, I distort the septum, change the compliance of the left heart, reduce its volume, and compromise its function. And then by decompressing these people, and we do this with our renal replacement therapy or aggressive diuretics, if you decompress this right ventricle, then you allow function to return, and you can actually improve function in many of these patients by actually taking off volume that was what I call wasted preload. Now, the actual interaction is complex, and I won't go into it for the sake of time, but this paper by Mon et al. In AJP in 1987 points out that what's really important is the actual compliance of the RV free wall, the compliance of the septum, and the compliance of the LV wall. So you can't exactly always predict which way things are going to go. So if somebody had a large infarct in the septum, you're going to get a very different response than somebody who doesn't. Okay. So what about tamponade? So in tamponade, you've added this fluid around the heart, and when that happens, the whole pericardium is now at a relatively constant pressure. During inspiration, you would get the same kind of phenomena. You got forces that are driving the increased flow to the right side, so that's going to push the septum over and compromise the left side, and therefore contributing to that decrease in left-sided output and exaggerating it, causing the smaller stroke volume. And then on expiration, then it can come back again, and so the left-sided output is recovered, producing the pulsus paradoxus. So during expiration, though, the other part that's going on is that series effect. So you have increased filling to the right heart, and now has to march through the lungs and get to the left side, so restores it, and then brings the pressure up. Now, it's important to remember, I should have actually said this earlier, but in pulsus paradoxus, remember that the pressure is going down on inspiration versus what you were hearing from the other speakers is what's called reverse pulsus paradoxus. The decline is during the expiratory phase. Remember, they're different. Okay, so the last thing I just want to finish up on, and in terms of that constant pressure, so what I pointed out here is the pressure remains unchanged in the pericardium. So another very important clinical sign is this one. So this is looking at a CVP tracing. Here was the pressure at 15, maybe going down to 12 during a breath. And you can see nice Y descents. So here's that same tracing. And then a few hours later, you'll notice the Y descents are gone. Very important clinical finding. That means they've tamponaded, because what's happened now is all the pressure in that pericardial compartment is constant. So you can get some volume into the right, but then you lose it on the left, and then you get it out of the left, you lose it on the right. But it never changes, and so you can never have this drop in pressure, which is the Y descent. So a very important indication of tamponade. And here, a leader was taken off, and the Y descents are back again. So summary of the mechanisms: the asthma type primarily changes in pleural pressure on the right and left heart. Possible role of RV loading, I think that probably is significant, and augmented by recruitment of expiratory muscles, that abdominal effect. The tamponade type, exaggerated filling of the right heart, afterload transmitted effects on the left ventricle, and a major role for ventricular interaction in this type. Thank you.